Okay, just a quick little information session here about pain in children. The biggest thing, or one of the biggest things with pain in children, is that we have to use the appropriate scale. I know when we talk about adult patients, we automatically think of the numeric scale. However, think about children being unable to communicate or actually understand what that numeric scale means. So there's different options available to us. The Flacc pain scale is appropriate for your little kiddos 2 months up to 7 years of age, and I'll show you an example. It's kind of like a observational pain tool, and then based upon your assessment findings, then you can give the pain a number for the child. You're all familiar with the FACES pain scale as well, probably previously for your non-English speaking patients. But they can also be used for kids, and we have an example of that here in just a second too, as long as the kid is greater than 3 years of age. The Alger pain scale, very similar to the FACES pain scale, but you show the child pictures, and they order those pictures, they place them, the picture that they see as most painful, they put at a 10, or at the top, and then the picture that they see as no pain they put at a 0 or at the bottom, and then they pick what picture represents their pain, and that's appropriate for ages 3 to 13. And then the one you're all familiar with, the numeric pain scale, it's not appropriate, and different textbooks will vary their age just a little bit, but consider the child has to be greater than 5 years of age, so they have to be at least school aged before you can use the numeric pain scale appropriately. There's the non-communicating children's pain checklist, and I have an example of that in a few slides. It's appropriate for kids greater than the age of 3. Here's a picture of the Flacc pain scale. Like I said, it's based upon your assessment findings of the kid. So F stands for face, L stands for legs, A stands for activity, C stands for cry, and C stands for consolability. For their face, they get a 2 for constant frown, clenched jaw, quivering chin. Legs, they get a 2 for kicking or drawing up their legs. Activity, they get a 2 for arched, rigid, or jerking. Cry, if they cry steadily, scream, sob, or have frequent complaints. And then consolability, they get a 2, difficult to console or comfort. And then, of course, the scale or the number would be lower based upon if they didn't have those high pain levels or whatnot. And I will post this so you guys can refer to it yourselves. Again, the Flacc pain scale is appropriate for kids 2 months to 7 years. Here is the FACES pain scale, which I said you all were probably familiar with it for non-English speaking patients. You'll also hear it referred to as the Wong-Baker scale. This is appropriate for kids greater than the age of 3. They can point to the face that best represents their pain. Here's an example of the Alger pain scale. So they have actual pictures. It's similar to the FACES scale, but the kids will arrange the pictures from what they think represents hurting versus not hurting. Then they choose the picture that best describes their pain level. It's appropriate for ages 3 to 13. This is the one we're all familiar with, the numeric pain scale. Again, the kid has to be at least school age, greater than 5. If they have a hard time understanding that this side is worse pain than this side, you could turn it upside down where it looks like a ladder. So their pain climbs, climbs the ladder. Here at the very top is the pain being worse, and then you can go down the ladder for less pain. This is an example, and I know it's hard to see, for the non-communicating children's pain checklist, and it is completely based upon assessment findings, obviously, because your child can't communicate with you. I don't expect you to just know it's an option based upon assessment findings. Atraumatic care, so you will see that word over and over again when we talk about pediatric care. Some things we can do to make things more comfortable for children. Provide treatment rooms, avoid traumatic procedures in a child's safe place, such as their hospital room. Offer child choices if appropriate. We want to let them have as much control as possible. Allow parents to stay or hold the child during procedures, but never restrain a child. You must know never to restrain a child. If you see a question that has the word restrain in it, be very cautious on picking that. Use play therapy. Also, we offer distraction, relaxation, guided imagery, swaddling or holding, rocking, non-nutritive sucking, kangaroo care. All of that's going to help soothe your child and make their experience better. Pharmacological measures in children. The World Health Organization recommends using a two-step approach. So as long as the kid's greater than 3 months of age. Now with the NSAIDs, it's going to be a little bit later before they can take those, but offering a mild pain relief such as acetaminophen or NSAIDs before offering the opioid. The second step would be adding the strong opioid to that, so they'd kind of have a two-step approach. For kids, give meds routinely instead of PRN if for severe pain, so that way we stay on top of it and it doesn't get out of control. Routes for pediatrics, oral is preferred. IM injections are not recommended for pain control because they hurt and they're traumatic. Intranasal meds are not recommended for pain control. Rectal meds are not recommended. The procedure's traumatic. They have variable absorption rates. If the child's unconscious, we may use rectal meds, if that's the preferred route. Intradermal meds are used for numbing the skin prior to a painful procedure, IV insertion, needle sticks, things like that. IV can be used if rapid pain control is needed.